start if you want.
Okay, salam everyone. My name is Nazia Kulsumeki. I'm a pediatric nephrologist and I work here at University of Illinois. So I thought this will be a good topic for you guys to kind of know some basic stuff with peds nephrology, especially what are things that you might come across on your regular training and also maybe when you start practicing. This I think is helpful for any physician, not just pediatric nephrologists, but even general physicians. So the topic is congenital anomalies of kidney and urinary tract. It's abbreviated as CAKUT or CAKUT, as some people say. And okay, yes, it is not moving now.
Maybe I should, if you want to share your screen, maybe.
Is it not sharing the screen?
Maybe try again.
Oh, there you go. Okay.
Okay.
Are you able to see the screen?
I'm able to see it. Dr. Meister, can you see it?
Yes, we do.
Okay, great.
Go ahead, congenital anomaly of the kidneys and urinary tract on my screen now. Okay.
Okay, sounds good. We'll go over the objectives. So basically, we'll talk about the epidemiology of CAKUT, talk a little bit about what normal renal development includes, different disorders that is under this broad terminology called CAKUT, and then also to look at how do you evaluate them and what are the outcomes of these patients who have these, basically these disorders. So CAKUT basically includes all the structural malformations of both the kidney and the urinary tract. And broadly, they can be divided into three main groups. One is parenchymal malformations. Under this comes your renal agenesis, hypoplasias, dysplasias, hypodysplasias, multicystic dysplastic kidneys, and then anomalies of the renal migration includes your pelvic kidneys, horseshoe kidneys, and lastly, anomalies of collecting system. This includes your duplicating collecting systems, megaureter, vesicourethral reflux, uretroceles, uretropelvic junction obstruction, and also posterior urethral valves. So overall, if you look, of course, I don't know the incidence back in Palestine, but if we can actually generalize this up to 0.3 to 1.6% of live births can have CAKUT disorders. And if you have a family member or offspring of CAKUT, then the chance of the other siblings being affected is always higher. And this encompasses almost 20 to 30% of all your congenital malformations. And renal anomalies, especially, they are associated with almost 200 syndromes and up to 30% of all chromosomal anomalies. So that is why it becomes very important that if you have a fetus or an infant with any kind of birth defects, then it is recommended to always get a renal sonogram to basically make sure that there are no CAKUT anomalies present. And why it is ultimately important for us is almost 30 to 50% of these patients encompasses our end-stage kidney disease. And if you look, these are two studies that basically highlight that, almost the top three causes of end-stage kidney disease include obstructive uropathy, most commonly your posterior urethral valves, aplastic, hypoplastic, dysplastic kidneys, and then the reflux nephropathy. The other causes of kidney failure like GN, cystic kidney disease, metabolic kidney diseases, even HUS, these are all other causes that encompasses the rest of the 50% of end-stage kidney disease. So the normal kidney development, basically kidney develops in three stages, the pronephros, mesonephros, and the metanephros. This is going back to your embryology. Pronephros and mesonephros appear at the same time, and roughly it is around 4th to 5th week of gestation. And these are basically rudimentary structures. They are transient, so they do disappear or involute over time. Essentially, they are these tubules, which essentially they join the mesonephric duct on both sides, and the mesonephric duct opens into the cloaca, which ultimately forms your bladder. And all these structures disappear except for a part of mesonephric duct does remain back and form a structure for, or like contributes to the gonads in males. Metanephros is the ultimate kidney that develops around the same time that pronephros and mesonephros is involuting, around the 5th week. This basically develops as a from the mesonephric duct. There is an outpost called the ureteric bud. The ureteric bud then stimulates the surrounding mesenchymal cells to undergo transformation to form the ultimate kidney. And there are a lot of factors that are essential here, both signaling factors, genetic factors. So the people have identified many of these specific signals. If they do go wrong, what kind of defects you can see. So ultimately, the metanephros then develops the kidney, and they are present in the pelvis. And as the baby's hind guts elongates, they eventually migrate and come up to the upper lumbar area, right under the diaphragm. Uh, that's where the ultimate location of your definite kidneys are. So a lot of things can go wrong during this time. And what is important is kidney development starts very early on. So 5 to 6 weeks of gestation, which is when typically most women will know that they're pregnant. So the kidney development has already started. And by 8 weeks is when the kidneys migrate to their retroperitoneal location. And urine production starts around 9 weeks. And when we refer to urine production, basically we are saying the fetal urine, and that contributes to your amniotic fluid. And from 9 weeks to 36 weeks, the kidney matures, more and more nephrons are added, and kidney development doesn't complete until 36 weeks of gestation, which is 8 months of pregnancy. And this is very essential to know. The reason being, now that we see a lot more kids who are born with premature birth, they are at high risk for developing kidney disease in general. This is because they have less renal mass, or we say less nephrons. And regarding the pathogenesis, there's basically multifactorial. There's a lot of genetic and environmental factors. There are many mutations that are identified in different genes that can be associated with abnormal kidney development. A lot of copy number disorders, by which I mean trisomies, deletions, duplications, they're all associated again with kidney diseases. Now that they are doing more of whole genome sequencing, it's become a trend right now to do all these tests. Whenever you have more than 2 system disorders, we're identifying more and more genes. So there are people right now created like a lot of registries where they're entering all these unknown mutations and trying to find a correlation. And then the second is environmental factors. We do know that if pregnant women are exposed to ACE and ARBs prior to pregnancy, and they conceive, then those definitely can cause abnormal kidney development, maybe even absent kidney development. And then vitamin A deficiency, very common in some of the women. So let's go into details of each of these disorders, starting with renal hypoplasia. Renal hypoplasia, essentially, hypoplasia means small kidneys. And in this situation, what happens is there's less kidney nephrons. So a normal kidney will have 1 million nephrons on either side. So in hypoplasia, we basically say there are less than 1 million nephrons. There's no test to actually measure how many nephrons, but essentially the only way they will present is they will have small kidneys. And it is believed that there is some kind of developmental arrest around 14 to 20 weeks of gestation. And the criteria to diagnose this would be when you do a sonogram and the size of the kidney is 2 standard deviations below the mean for age. So everything in pediatrics is about age and sizes depending on those ages. So we do have normal, kidney size measurements based on sonographic measurements for different ages, and that's what we would refer to. And the way to basically diagnose this is a hypoplastic kidney is, so hypoplastic kidneys are still functional kidneys. So you can do a DMSA scan, dimercaptosuccinic acid scan, and basically that will show that the kidney is able to pick up the dye. And in this picture here, right here in the middle, you can see that there is a good cortical uptake. It's just that the kidney is small. Then renal dysplasia. So renal dysplasia is where there's not normal kidney tissue elements, and essentially the nephron is replaced by other mesenchymal or epithelial elements. There could be cysts, there could be cartilage, there could be just fibrous tissue. And not only are these kids at risk for having less nephrons, but also decreased function. Again, the way they would present would be similar with small kidneys, but also have other features. So cysts, they could be a little echogenic kidneys. Most of the times it tends to be unilateral, but can be bilateral. And if you look, a male to female incidence ratio is slightly, more common in males. And for bilateral to versus unilateral would be 1.9 is to 1. And in renal dysplasia, these are kids that are high risk to have abnormal kidney function right from birth. So these are kids that we would follow long term. And in general, most of these defects, they are picked up prenatally on their routine anatomy scan, confirmed with postnatal sonograms. If you have bilateral renal dysplasia, because they're at risk for having CKD or decreased kidney function, there could be a history of oligohydramnios. And on ultrasound, as I already said, they will look echogenic, will have cystic kidneys, they will be poor corticomedullary differentiation. And if you do have bilateral dysplasia that is very significant, some of these kids can even present with, almost like a Potter sequence. And we'll talk more about it. And also to remember is, whenever you have both hypoplasia or dysplastic kidneys, there could be associated other urological abnormalities. There could be reflux along with it. There could be some bladder issues. So always these kids are, children that may be at high risk for developing UTIs. So we do voiding cystourethograms in some of these kids who may have other signs of hydronephrosis. So this is an ultrasound basically showing how we look at the kidneys. So on the bottom is a scan, that's a normal scan. There is liver, and then you have the kidney. The cortex of the kidney looks very isoechogenic to your liver, whereas on the top scan, on the top picture, the kidney looks very echogenic. You don't see the cortex and the medulla well differentiated. And if you look closely, there are also some microcysts. Next condition is multicystic dysplastic kidney. So we always use this term called MCKD. Whenever we refer to this terminology, it's basically telling you that that kidney is non-functional. Again, like your dysplasia, there's a lot of abnormal kidney tissue here, but they don't have normal nephrons. So most of the kidney is just replaced with non-reniform, structures, cells, connective tissue. They will appear like large cysts. Most commonly tends to be unilateral, and for some reason, mostly on the left side more compared to right. Again, directed on prenatal routine scan, and of course confirmed postnatally. And as you see here, like on the last two pictures in the bottom, these are all kidneys that were removed. There's always this question of when do you remove a kidney if it is not working? So we, in the last 20 years, practice has kind of changed. Previously, when there were a multicystic dysplastic non-functioning kidney, then they would remove it. So what now we do is, If it is not causing problems, meaning if the cyst is not enlarging too much, it's not causing pain, there's no hematuria, there's no urinary tract infections on that side, which by which I mean if there is any reflux associated, there's no concern for unusual growth, tumors. We tend to leave these multicystic dysplastic kidneys alone. Most of the time, by the time, oops, by the time the kid reaches age 5, these tend to involute. In some cases, the first year you may see these kidneys grow a little bit and then start involuting. So what is recommended is to do annual sonograms on these patients just to follow those kidneys. And if it is unilateral, then in that case, if you have a contralateral normal kidney, you would expect that kidney to show hypertrophy. So as probably you already are aware, for having a healthy life, all you need is one normal kidney. And in kids, the good thing is they are growing. So if you have a normal kidney, then there's a good chance of hypertrophy. So in that situation, what we do is we follow these kids up, make sure that they're getting annual sonograms, make sure the contralateral kidney is showing hypertrophy, and also to check and make sure these multicystic dysplastic kidneys are undergoing involution. Next condition is renal agenesis. As the term explains, it's basically when you don't have a kidney. And what happens is there is a disruption at the time when the metanephric development is happening. So it could be that they don't have appropriate signals or genes that are required for the ureteric bud to stimulate the metanephric mesenchyme. And essentially, you may not develop that kidney on that side. Tends to be again more common in males and accounts for up to 5% of renal malformations. Again, found on a prenatal sonogram. The thing is, when you have only one kidney, you want to make sure that there's no other CAKUT disorder associated with it, by which I mean reflux, obstruction, because now you have one normal kidney, you want to make sure that kidney is completely growing well and healthy. In situations when you don't have both kidney development, which would be a bilateral renal agenesis, is when you would see something called Potter syndrome. This is, like how we say a board favorite question, where they will describe to you a baby who has oligo or even actually anhydramnios. And the baby has wide spaced eyes, epicanthal folds, broad flat face. Some of these babies are born have fetal demise, or they die immediately after birth. And the reason being, the fetal urine or the amniotic fluid is so essential for your lung development. And these kids have very severe pulmonary hyperplasia. So as soon as they're born, they can have fulminant, very severe pneumothorax, and essentially can die from that. Like the previous condition where I mentioned, you can have bilateral renal dysplasia, severe renal dysplasia. They could also present with similar Potter syndrome. So prognosis depends whether it's unilateral or bilateral. Unilateral tends to have a better or excellent prognosis only because you have a contralateral normal kidney. And in most cases, as I said, it'll undergo hypertrophy. When we refer to hypertrophy, what we are saying is they have 1 million filters, but essentially they become bigger. They don't add more filters. Whatever remaining filters they have, kidney filters, which nephrons, they become big and contribute to the hypertrophy of that kidney. When you don't see that hypertrophy happening, then those kids are at risk for CKD. So it is recommended for most kids with renal dysplasia that we do yearly blood pressures, even from the time of birth, urine analysis. This is again to watch for proteinuria. And creatinine function, typically I tend to do it when they reach age of 2 to make sure they have normal GFR, and then do annual sonograms, follow the growth of the kidney. And at any point, if I don't see the hypertrophy, then I start doing serial serum creatinines to see if they're developing CKD. And CKD stands for chronic kidney disease. This is another side topic that also comes about during our discussion, whether these kids who have single kidney and they have undergone hypertrophy, and can they be allowed to participate in sports? And this is basically important because most kidneys, if they are in normal location and they are normal in size, they are well covered by your ribs, and they lie right under the diaphragm. So the risk for injury from any kind of direct contact is less. But once they undergo hypertrophy, these kidneys are more palpable. So any kind of direct trauma would cause kidney lacerations, contusions, and most of the times, if it is very severe, then they may lose that kidney. This was a study done in 2012, which is where the now recommendations have come to the American Academy of Pediatrics. If you look overall, the sport-related injuries, the kind of sport-related injuries we see is mostly head and neck injuries with all kinds of sports, and the kidney injuries are way less compared to head and neck injuries. Sorry, I don't have my pointer here, but it's the second and the third column that I'm referring to. And football, which is your American football, I think it's also the other name is rugby, is a very highly competitive sport. There's a lot of contact, kind of a rough sport, and that is the only sport that's associated with slightly higher risk for kidney injury. And what I tend to do in my practice is, depending on what the parents, uh, basically interests are, or even the kids' interests, uh, I don't have this discussion very early on in their life, but once they enter middle school or high school, when they're in sports, I do give them the statistics. I tell them that there is increased risk, but again, it's basically more like an informed decision for the parents to be aware that there is potential risk of kidney injury if they are in a situation where they are, get a direct blow to their belly or are tackled down. The second subset of these disorders is basically disorders of your renal embryonic migration. So first, starting with renal ectopia. So whenever we say renal ectopia, essentially means the kidney is not in its normal position. Most of the time tends to be pelvic, but essentially can be anywhere from pelvis all the way to the normal location. It can be in any of that along that track. There is slightly increased risk that pelvic kidneys may have vesicourethral reflux. The reason being, if you imagine the kidney is located in the pelvis, the ureter is going to be short. Sometimes a ureter may be ectopic, may not insert in the normal position. So they may be at increased risk for vesicourethral reflux. So a VCUG may not be a bad idea to do in these patients. And majority of them, again, remain asymptomatic. Some of these kids may develop UTIs, obstructions, or stone. Horseshoe kidneys, where your kidneys are fused so the lower poles of the kidneys are fused, and they fuse right in front of the spine, and the fused segment is called isthmus. So what happens is, as the kidneys grows, also the isthmus will grow, and the ureter tend to face more anteriorly, so they will come out of the kidneys. They have to traverse over the isthmus, so there may be slightly at risk for obstruction, and that causes stagnation of the urine. And essentially with that, increased risk for UTI and stones. Other than that, you can have other anomalies. You can have fused kidneys basically on the same side. There can be both the kidneys on the same side, but not fused. The kidneys can switch over and the ureters are in the normal place. So, you can have a bunch of these things happen, especially with malrotation, uh, malrotation kind of syndromes. Next is anomalies of collecting system. So again, they are divided into these different segments. So first, starting with the duplicating collecting system, disorders of the renal pelvis is the UPJ obstruction. Ureter could be megaureters, ectopic ureters, uretroceles, vesicourethral reflux. Bladder could be bladder extrophy, and lastly, the urethra, which is the posterior urethral valves. So in duplicating system, Again, this is the most common congenital anomaly of the urinary tract. Up to 5% of autopsies of the fetuses have revealed this. And what happens in this situation is there is either complete or partial duplication of the ureter on one side. So the upper ureter tends to drain the upper pole of the kidney, and the lower ureter will drain the lower pole of the kidney. And if there are two different ureters starting from the kidney, they might insert into two different places in the bladder. The upper ureter tends to be a little lower and tends to be more ectopic, so it'll insert lower, and the lower ureter will insert in the normal position. So with that, what happens is the upper segment tends to have more reflux, can also have obstruction. The lower ureter that drains the lower part of the kidney can also have reflux. So essentially in duplicating systems, it is very, very important to do VCOG to make sure there's no reflux. And I apologize, I think my picture is kind of overriding my slide, but I hope you are able to see those things that I mentioned. Then next is uretropelvic junction obstruction. In this situation, what happens is there is basically a narrowing at the junction where the ureter and inserts into the kidney. So what happens, as I had explained, the metanephric mesenchyme forms the kidney, the ureteric bud forms the ureter. So it basically inserts into that. So there could be a narrowing at the junction. And most of the times, so this is one of the most common findings that we see, which we basically term it as hydronephrosis, and more common in males. Tends to be more common again on the left side. And the way the ureter actually develops is the ureter is actually a solid cord. So the cannulation of the ureter happens later. So there could be some areas naturally where the ureter did not completely open. So in that situation, there may be some narrowing that may persist, can cause even partial obstruction, or in case if it was completely not open, can cause complete obstruction. Other than that, so uretero-pelvic junction obstruction most of the time tends to be from intrinsic causes. Extrinsic causes could be from some abnormal blood vessel crossing over the ureter that basically causes the obstruction, or even tumors, masses, stuff like that. So it'll appear as hydronephrosis. You will have a dilated renal pelvis along with dilated renal calyces. So this is again a picture that basically depicts that. So you have the upper ureteric dilatation. Again, you have to remember when we do a sonogram, all you can see is the kidney, the upper part of the ureter, and then the bladder. You can't actually see the whole length of the ureter. So in this situation, like in the lower part, you can see the kidney is very dilated. You can see the calyces are dilated. The cortex is completely pushed to the periphery. And then on the side, you can see a circular finding that's basically the ureter that's dilated. And if you look, if you do a bladder scan in this patient, then the ureter will not be dilated in that situation. And the reason why it is important is that's the only way you can differentiate this versus a megaureter. So primary megaureter, again, what happens in this situation is there could be a functional or an anatomical abnormality at the uretrovesical junction obstruction. Uretrovesical junction. So uretrovesical junction is the point where the ureter inserts into the bladder. And this is the second most common cause of neonatal hydronephrosis. Again, tends to be more common in males, tends to be more common on the left side. What happens here is basically there's either an anatomical cause or there's delayed development of the muscle around the distal ureter, around 20 weeks, essentially making that part of the ureter not develop normally, and causes more like an obstruction or narrowing. So the rest of the ureter becomes a reservoir. So whatever urine the kidney makes then kind of stagnates into the whole system. They are different kinds. There are, megaureter can be associated with reflux or with obstruction. And then you can see a combination of things. You can see a refluxing, but a non-obstructive ureter. You can see a refluxing, also obstructed ureter, non-refluxing, non-obstructed ureter, non-refluxing and obstructed ureter. So the only way to know if this ureter is refluxing is you would do a VCUG. And for obstruction, then you would do more like a renal functional scan, and we'll talk about it. So this is a LASIK scan or a renal scan that we do. And on the lower bottom, you see first going through the sonogram, you see the bladder, you see the right ureter, which is very dilated compared to the left ureter, telling us that the ureter is dilated all the way from the kidney down to the junction of the bladder. You also on the B, you will see a hydronephrotic kidney. C is basically the normal left side, the right side kidney. So in a nuclear med renal scan, what they do is they use a contrast called MAG, and it's given through the vein. The dye goes into both the kidneys. In case of obstruction, there may be a slightly delayed uptake. You may see the brisk uptake on the normal side and slightly delayed uptake on the contralateral side, and then the normal kidney will immediately start excreting the dye, and you can see the whole path. Whereas on the kidney that's obstructed, you may see the delayed uptake, delayed excretion, and midway through the scan, they give Lasix. There is again a quick response on the normal side. You completely excrete the dye within a few minutes, whereas on the left side, in this case, you see the delayed excretion, and you can see the dye is still remaining in the system all the way down to the last, scan at 19 minutes. So what they then do is they basically create these graphs, and again, basically confirming the same thing, that the left system is obstructed. Where you see after the Lasix, there was not much activity on the left side. The dye remained in the urinary tract system till the end. So ureter seals. Ureter seals are also some common defects that you might see. They basically appear like cystic dilatation inside the bladder. So they're basically dilatation of the submucosa. And what happens is normally your ureter will insert into the bladder. The ureter buries into the bladder wall. So there could be an outpouch of that ureter in the submucosal aspect, and that forms a cystic lesion that actually comes into the bladder. So 1 in 500 newborns can have this. Tends to be more common in females, more so common with duplicating systems. Whenever you see a ureter seal with a duplicating system, then you have to be concerned about obstruction. The reason being, these ureters, even though they're located inside the bladder, they can act like a flap. So they may move up and down, and they may let the urine kind of go backwards, but at the same time they flap back onto the opening and cause obstruction of the ureter. Can be unilateral or bilateral, and in most of the case, when you do a sonogram, you will see this is how it will appear. There will be a separate cyst within the bladder, and when you do a VCG, you may see that the part where the cyst is not filled with the dye. And the surgery for this is very simple. Basically, they would do something like a cystoscopy, look at the cyst, and essentially open it up. And by doing so, if there is obstruction, then you can relieve the obstruction. So it is important that those are taken care of as soon as possible. Next important disorder is vesicourethral reflux, or VUR. In this situation, what happens is urine should always flow in one direction from the kidney to the bladder. And what happens is some urine, a portion of the urine that comes into the bladder, then refluxes back into the ureter. And a normal ureter inserts into the bladder in a segment called trigone. And the ureter will insert in at a certain angle, and then also bury into the muscular portion of the bladder, and open a little distally from where it inserted, which is almost like it is tunneling into the bladder wall. And this is very important because once the bladder contracts, then it basically compresses and squeezes shut the ureter. And if this doesn't happen, then you can have reflux. So in patients who have vesicourethral reflux, it could be that the ureter is inserted not in the normal position, which is the trigone. It may be ectopic, or it may insert at a very, obtuse angle, or it may just bury very superficially. So in those situations, the reflux can be very prominent. Again, reflux also can look like hydronephrosis on a prenatal sonogram. And most of these patients will develop urinary tract infections. Tend to be more common in females, tends to be again more common in Caucasian people, and can be unilateral or bilateral. Reflux, you have different grading. The grading is depending on the VCUG, to see how far or how severe the reflux is. In grade 1 reflux, the urine basically just goes up to the portion of the ureter. Grade 2 would be the urine is refluxing all the way to the upper part of the ureter. Grade 3 is it is refluxing all the way into the kidney. Grade 4 is when it enters the kidney and then also start causing the dilatation of the pelvic ileal system. Grade 5 is to such a severe degree that it's almost like causing the whole the calyceal system to basically become balloon and push the whole renal cortex to the periphery. So that grading is based on your VCUG. And it is important to know, the reason being, with the different studies, we do know that severe reflux has lower chance of resolution, and basically high risk for pyelonephritis, renal scarring, renal dysplasia, and also CKD. And if you look low grade reflux, there is a chance that it may resolve. The reason being, normally in a child, the bladder doesn't attain its full function until the time they're toilet trained. So 3.5, 4 years is when their bladder musculature is strong enough. And say the ureter were superficially buried, or they were not angled properly, there's a chance that those defects may go away, and that as the bladder becomes more strong, that it's able to completely close those junctions. So low grade reflux can resolve, and people have developed these algorithms, and we basically use it in our practice too, where essentially if you have grade 1 reflux, the chance of its spontaneous resolution by the time you're potty trained, or like 1 year of age, is 72, but by the time you reach 5 years is almost 80 to 90%. Whereas if you have high grade reflux like grade 4 and grade 5 reflux, the chance of it completely going away is low. It may get better. So it may get better from grade 5 to grade 3, but the chance of it completely going away is not high. And reflux is very important because not only is it causing urinary tract infections, but it also causes scarring. So there are studies. One of the main landmark studies is your reverse study, wherein they did this randomized control study to look at kids who were on prophylactic medications compared to kids who didn't have prophylactic medications. And what they found is ultimately, even with or without urinary tract infections, they are high risk for developing renal scarring and high risk for developing CKD. So we know that even the kids who are on prophylaxis, their long-term outcome for kidney disease is still very high. So this is a reverse study, and as you see, I have highlighted here the kids who were on Bactrim prophylaxis compared to placebo. The urinary tract infections were definitely lower, but ultimately it did not change their renal scarring outcome. So this is again a big debate. The reason being, you would definitely want to prevent urinary infections, but the problem is, if it is low grade reflux and it's going to get better on its own, you're potentially exposing these kids to long term antibiotics, and they may develop antibiotic resistant UTIs. And what does that mean for their overall outcome? So the practice has kind of changed. I tend to be a little more conservative. If I feel like it is a female, if it is bilateral reflux, if they have other defects that may put them at a high risk for UTI, I still even prescribe prophylactic antibiotics for low grade reflux. but a lot of people have started to now, leave low-grade reflux like grade 1 and 2 untreated, as long as they're watching for signs of UTIs. So this is where the renal scarring did not change in these two groups. And basically developing resistant pathogens more common so in the treatment arm. Last condition is your posterior urethral valves. This is where basically this only affects your males. And here what happens is in the posterior urethra, normally, there's no folds, and they basically develop this obstructing membranous fold, and it can be partial or even complete. And most of these kids will have history of oligohydramnios during pregnancy. At the time of birth, they have distended bladders. The bladder wall is very hypertrophic, very thick, and then they may have bilateral hydronephrosis, one of the most common cause of end-stage kidney disease in these patients. And the kind of reflux they develop is secondary. So in this case, what happens is bladder basically distends, and they have increased pressure within the bladder that basically causes reflux into the kidneys. And this is bad. So the bladder may look very distorted, may look like almost like how they describe a Christmas tree, like neurogenic bladder. They may have trabeculations. They may have, sometimes even they develop outpoaches, fistulas. And on a sonogram, it will show this keyhole sign. So the bladder in the posterior urethral valve is dilated. It almost looks like a keyhole, and that's basically pathognomonic for this syndrome. So this is what we would look for. And on this, on the right side, you see a VCUG, and you see the reflux on both the sides, and basically shows a dilated bladder, trabeculated bladder, and also the dilatation of the posterior urethra. So this is the most diagnostic or like confirmation of posterior urethral valves. So two tests: either you do a VCUG or you do a cystoscopy to actually visualize the posterior urethral valve. Um, Pluto was a study that was done many years ago, and this was basically to look at kids who had severe oligohydramnios with posterior urethral valves. Again, as we all know, fetal urine or the amniotic fluid is very important for lung development. So this study, what they did was they wanted to see if somehow they could drain the bladder during the time of gestation, whether they could prevent both the lung hypoplasia and also prevent renal dysplasia. So what happens is if you have a obstructed system, or you have a bladder obstruction, that itself can cause more renal dysplasia. So the Pluto study was designed in such a way that they did fetal surgeries, created these vesico-amniotic shunts, making the bladder directly drain into the amniotic fluid, and see if that would basically help the lungs mature and that the survival would be better, and also to see if these kids did not have such bad renal dysplasia. And they divided, basically they had two arms. They selected a group of patients who underwent this procedure around, I believe, was second trimester, around that time. And what they found was they had same number of live births. There were more death in the non-intervention arm. There were more surviving after the intervention, but ultimately the amount of renal dysplasia they had was similar. It did not change the outcome. So the problem with this procedure is there's a high risk for miscarriages, high risk for pregnancy loss. So even though this is done in some centers, it is reserved for only kids with or like infants where we feel like there is no other pathology. And of course the parents are told that the risk for with this procedure is, one, loss of pregnancy. Second is that the kidney development and dysfunction may not go away. Third is also what do you say, bleeding, hernias. so many other defects. So after discussing all these defects, ultimately the most important thing for you guys to know is standard practice right now with prenatal diagnosis is most of the pregnant ladies have one sonogram at the time of I guess confirmation of pregnancy, and the second is done around 20 weeks, and this is basically called an anatomy scan. And as you know, kidney development starts early on. So if they have defects, you may have a very high chance of deducting this at 20 weeks. And again, you may see defects like hydronephrosis, distended bladder, oligohydramnios. And if you don't have a center that does these kind of fetal surgeries, vesico-amniotic shunts, amnio infusions, things like that, then ultimately it's best to do postnatal testing. So also consider that if you don't see a defect at 20 weeks, if you have a normal anatomy scan at 20 weeks, but you have history of either oligohydramnios, if you have family history, if you have a IUGR baby or a dysmorphic baby, then also it is important to do a postnatal sonogram. Postnatally, most of these kids, they look, depending on when they're born, they may have either poor urinary output, sometimes even weak stream. They may have abnormal genitalia that you can see. And then ultimately these kids would need a sonogram and then maybe a VCUG. The other tests like renal scan, CT, MRI, urodynamics, cystoscopy, these are all more confirmatory tests and typically are done at a later age. Other than the sonogram and those other radiological tests that I mentioned, there's not much out there in terms of biomarkers. People do amniotic fluid assessment, amniocentesis, and there is definite data to suggest that if you have high sodium level or urinary sodium in the amniotic fluid, calcium or even beta 2 microglobulin, that there is significant renal dysplasia. Again, to do an invasive test like this is going to be a challenge, and typically done in patients where you feel like you're going to do fetal surgery. So it's not a standard practice in most places, but definitely if you are able to do it, then it does help you prepare the family ahead of time prior to birth, telling them what the chances, sorry about that, telling them the chance of kidney failure. Otherwise, postnatally, as I told, serial sonograms and creatinine measurements would be the best test you will have. So in summary, if you do have a kid or a fetus with hydronephrosis, what is recommended is to do a sonogram after birth, which would be around day 2 or day 3 of life. If you have unilateral versus bilateral hydronephrosis, again, there are different staging. I didn't go more in detail. There's something called Society of Fetal Urology grading. And if your renal pelvis diameter is more than 10 millimeters, unilateral or bilateral, then it is okay to go ahead and start them on prophylactic antibiotics like amoxicillin for UTI prophylaxis. Plan to do the sonogram postnatally and then do a VCUG. If the VCUG confirms reflux, then you can continue the prophylaxis. If there is no reflux, then you discontinue the antibiotics. Then have a plan to do another sonogram. Have a plan to do another sonogram at 1 month of age. And if the hydronephrosis is still present, then you can go ahead with your renal scan. By renal scan, I mean the LASIK scan. This is basically to rule out your UPJ obstruction. And typically we don't do this until 3 or 4 weeks of life. The reason being your GFR at birth is very low. You need to have significant GFR and significant urine output to see obstructive findings. So that would be the next step. So if you do find obstruction, then surgery is indicated. So urology needs to be involved. So ultimately, to summarize your CAKUT disorder, the takeaway message is you have to know that these kids with abnormal kidney development, abnormal kidney findings are still very high risk for developing CKD and ESRD. And the pathogenesis is multifactorial. Lot of times it's genetic, but some environmental factors are also uh, important to remember. Most of the times, the CAKUT disorders present as hydronephrosis, which is the most common abnormal finding that you see on a prenatal sonogram. And then, if you do have hydronephrosis, depending on unilateral versus bilateral, what are the findings you see? Upper ureteric dilatation, abnormal bladders, uretroceles, etc. Then you may want to then proceed with both VCUG and renal scans. So these are the main things. And then most of these kids do need annual sonograms to kind of watch the renal growth. And see, creatinine is again the only test we have to look at kidney function, and tends to be still a good test in establishing whether these patients are going to develop significant CKD long term. So with that, I will end my talk. And I can take questions if you guys have any. Hope that was helpful.
Thank you, Dr. Nazia.
Thank you.
Would you please send us the slides so we can distribute it, if you don't mind, to other residents who couldn't attend this lecture?
Sure, I can.
Okay, thank you. Actually, congenital anomalies of the kidneys, a topic which is we see such patient in our hospital, and we have a nephrology department. It's I don't know how much it's common. I'm not aware about the statistics, but we see we see many patients with such a problem. And really thank you for giving this review about this topic, which sometimes I feel it's neglected in the field of pediatric. Most of the residents, they focus on the parenchymal disease of the kids and glomerulonephritis. But I'm talking about myself. When I was a resident, we always avoid to study such things, and that is it. Like, despite it's important, but we find it difficult maybe.
Yeah.
So thank you very much for this lecture.
Yeah. So I do want to say, your GN, glomerulonephritis, and all those other things are not as common. And as I highlighted already, the kids who have CKD and ESRD are mostly from CAKUT. And this is something that you will come across in your practice, even if you're doing, hospital medicine, ER. This will definitely, in your lifetime, you will definitely see many of these patients. And the thing with kidney disease is you have to remember, these kids, unless they have UTIs or some other, really pressing things like growth failure and stuff, some of the times, you may not have any symptoms. And we see a lot of kids even present in fulminant kidney failure at a later age. So I just remembered, this is something I do want to share with you. Uh, in my training, I had an 18-year-old girl. She was from Palestine. The family had recently moved to America 2 years ago, and she came into the emergency room with symptoms of not feeling well. And her hemoglobin was, when they do the basic metabolic test, they had done some CBC, and her hemoglobin was really, really low at 6. And of course, her creatinine came back at 10, so they knew something was off. So first thing that came to their mind was GN. So they did the whole workup. Ultimately, just the sonogram of the kidney shows she had 7 centimeters kidney measuring both sides. So she lived 18 years of our life without having any symptoms presented with renal failure. So this is something that can happen, and underestimated. So I just wanted to kind of talk about this because I feel, even though we pay so much attention on all these fancy tests, biopsy, glomerulonephritis, this is something that you will definitely come across.
Yes, of course.
Okay, so thank you very much, and I hope it helps. And if you have any questions, you can always reach back, and I will share my presentation with you.
Thank
Thank
you,
you.
Dr. Nazia. Thanks for everyone who joined the lecture today from Anaja and all the new residents who joined from Palestine Medical Complex. Dr. Nazia will give 2 more lectures in January, I believe. I'll share the slide with you and the lecture recording. Thanks again. Hopefully to see everyone in the next lectures. Thanks, everyone.
Inshallah. Thank you, Dr. Rami.